I want to start by, one, thanking you all for being here. Last session, kind of making it through the marathon, so thanks for everybody for being here. And then, obviously, our expert faculty as well. Thank you so much for sticking around and being here for us and, let us pick your brain a little bit about some of the cases that I'll present to the group today. So I'll start with a little bit of introduction. Like I said, my name is Dhaval Tucker, interventional pulmonologist at the Southern Arizona VA. I also had an assistant professor at the University of Arizona through that position. But that's pretty much me. I have nothing to disclose about this session. I'll move on to Dr. Lentz. He's one of our local guys at Vanderbilt. He's also an interventional pulmonologist, very published in the field, and excited to have him and kind of his thoughts on the first case that we'll go with. We have Dr. Lam, and everybody's in perfect order without knowing, so it's perfect. It works out nicely.
Sometimes it works out.
And so, Dr. Lam, who's my mentor and trained me at Leahy Clinic when I was there for 7 years, but she's the director of the Interventional Pulmonary Medicine program there and program director of the fellowship, amongst many other hats, world-renowned lectures, and very involved in education and teaching the residents and fellows. So that's Dr. Lam. And Dr. Murgu, also very well known and published all over the world with a lot of these studies, working with the WABIP. He's the program director of the Pulmonary Fellowship at University of Chicago. With that, I'll get started. All right, so the objectives for today's session, we're going to be talking about an interesting case about and how you would work up and do staging workup for a lung cancer case. Followed by a case with endobronchial obstruction and kind of how you would manage that, discussing the utility of stents or not. And then lastly, a case about TE fistula that we'll talk about kind of how we would approach it. So I'm basically going to give just a little bit of information, enough relevant information hopefully to our faculty, and then kind of ask them how they would do these things. So please, feel free to grab the mic if there's a question, and we can make it as interactive as possible and as educational as possible for everybody. All right, so with that, we'll start with the first staging case. So we have a 72-year-old male, presents with new bilateral lung findings on a lung cancer screening CT. So there's a left upper lobe nodule and a more peripheral right lower lobe cavitary mass. Relevant history is the guy's an active smoker, 1.5 pack years since 17 years old, but really asymptomatic from a respiratory perspective and any other constitutional symptoms, and just happened to catch us on a lung cancer screening CT, at the age of 72. So we'll go through that, and hopefully we'll be able to show you. So I just have a few relevant slides on that. So that's... And Dr. Lentz, I'll start with you on these. Let me know if you want me to slow down or go back or anything and look at that again, but I'll scroll back up once more and then down once more to kind of just show you what that lesion looks like.
Did you mention that we haven't seen the cases?
Yes, no, I did not. Thank you. Yes, so they don't know anything about these cases at all, except for what I'm telling you.
We did ask.
So hopefully there's no gotchas here. It's not really, that's what I'm designing here.
It's a great opportunity to embarrass ourselves.
Exactly. And I'm going to go back down one more time, just scrolling through. And then this is the left upper lobe lesion that was seen in it. So, and I'll go back. Okay. One more time. All right. So I ask you, how would you approach diagnosing this patient? What would you kind of, or what information do you want? Kind of what would you, if there's anything else that you want, or kind of tell us how you would approach this?
Well, I'd want to look at, it wouldn't change, so based on what you've shown me here, I know that I'm going to do a few things, but I would want to know what the mediastinal and the hilar areas look like, at least as I'm planning the bronchoscopy.
Sure.
I'm going to tell you what I'm going to do.
Absolutely.
Any notable information you can tell?
Yeah, so I'm just going to go through this real quick here, and I'll show you the soft tissue kind of windows here, the relevant lymph node. And so, non-contrasted study, but this was just a radiology arrow sign here. Solid. Nice big obvious one, right? But as I come down here, you'll start seeing the left mediastinal area there. All right.
Okay.
So after that, any further information you would like, or?
I think based on this, I would probably start developing a plan. So
Okay.
there are multiple, okay, so your choice, you got bilateral disease. You can do a transthoracic needle aspiration of one of them, wait 2 weeks and go after the other one. You could surgerize this patient, or you could do a bronchoscopy. I would do a bronchoscopy on this patient for a number of reasons. One, bilateral lesions, you can target both in the same procedure. More importantly, though, both of these lesions have indications, pretty strong indications in my mind, for a full staging EBUS survey. So the right lower lobe lesion is 4 centimeters. It's a mass. It's not a 1A lesion. And so anything over 3 centimeters has, I think, fairly good data that deserves full mediastinal staging. So that alone buys this patient a bronchoscopy.
Sure.
And while you're at it, you can go after these other things. The left-sided lesion is still 1A. It's under 3 centimeters, but it's central. And so that also, at least per NCCN and even the ACCP, the older guidelines, should be staged because central lesions have a higher rate of mediastinal disease. So this patient deserves an EBUS, and therefore I think you should do the EBUS. And then there's some abnormal mediastinal findings here as well, which I'll talk about a little bit more in a minute. But so I would target all of these things. The other thing I notice about these lesions is that they're morphologically not quite the same. So they're both pretty sizable lesions. And so when I'm in the absence of clear mediastinal disease, which we'll get into here, there's always a question of, are these synchronous primaries, or is this a metastatic case? Is this stage 4 disease? So we could potentially upstage this patient to stage 4 in a single procedure if you can prove that this is a metastatic process. The fact that they have different morphologies, I think, makes that a bit less likely. And this is also tricky because most synchronous primaries are of the same histology. And so the fact that they're both different appearance and relatively similar in size, right now I'm leaning towards these being synchronous primary just based on those factors, but certainly I'd like to get biopsies of both.
Yeah, absolutely. I think that's very reasonable based on everything you said. The other thing is, where I come from, Coxie country, that's the other things, that especially not too many symptoms or anything like that. That's the other thing I always have to think about just because I'm in Tucson,
Can we ask questions?
Yes, please.
Dr. Lance, will you do a PET scan in this patient? And justify your answer if you don't mind.
So I live here where everyone inhales histo. Welcome. You all have it now.
That's why my voice is like that?
It might be. Check your recurrent laryngeal. I don't know. So I do not routinely get PET scans before just about any of my procedures here because the utility and Eric Rogan and Stephen Deppen in our group have demonstrated this. The specificity of FDG avid nodal disease here is a lot lower than it has been more widely published. And so it rarely influences what I do. And this patient needs systematic staging. Now, you could pick up extrathoracic disease potentially, but you still have a situation where you might have a curable, one of these could be a curable lesion. And so even if there's a liver lesion and you find adeno in it, this the left upper lobe thing might be a squame that could be cured, while you do, you're not going to surgerize a stage 4 patient with another primary. I would still want to go after all of them.
But I'm going to ask, is there a PET scan?
Yes.
There probably is. The other thing that we might talk about here, it looks like there's some station 5 disease or station 6 disease that is not going to be accessible probably to us that could come into play here.
Yeah, exactly. So yes, Dr. Lamb, there was a PET scan, and the way I got this was very different how it came to me. But if it had come to me first, this is exactly why I want to kind of bring it up as an interesting kind of case from that perspective. But so I do have a PET scan, and I just have the PET man, one of my favorite views of it. But so as we turn PET man around, so you see he's got a lot more PET avid disease kind of on the left in the mediastinum. And this was red. I'll tell you what our radiologist had given us. So I'll just have PET man spin around and go here. So PET CT findings. So the left upper lobe nodule in question was an SUV of 14. The right lower lobe mass was 5.9. Subaortic lymph node at 17. Left paratracheal, lower paratracheal was 13.7, and right upper paratracheal 3.2.
So some evidence, the hotter the node on PET, the more likely it is to spread to the mediastinum and elsewhere, so obviously concerning PET scan. Even without the PET, there was, by CT criteria, these nodes were abnormal.
Absolutely.
And again, even by the size of these lesions, deserve a full systematic survey. So I would do bronchoscopy first. I suspect we're going to find at least stage 3 disease in this bronchoscopy, and hopefully not have to go after that subaortic node, which would require a different procedure.
This is getting interesting. Can we ask questions?
Yeah, please.
What kind of bronchoscopy are you performing, Dr. Lentz?
Which, what?
I mean,
Yeah, okay.
like, are you going for periphery or are you
Yeah,
going
yeah.
for
Good question.
lymph nodes?
In this case, I don't know that there's definitely a right answer in this case. I suspect we're going to get disease in the nodes, and so in that situation, you could potentially save time and cost by just doing the EVIS. But I'm still concerned these are distinct processes. And so I think I would biopsy both parenchymal lesions as well as all the nodes to try to sort out exactly, to stage this patient as accurately as we can. And in that case, when I'm going to get the periphery anyway, I start with that. So I would start with navigational robotic, go after both primaries, the right lower lobe probably first, and then I would stage the mediastinum. What would you do?
I was waiting for that. I think I would start with sampling the right peritracheal lymph nodes. We use rapid on-site evaluation. And if that's positive for tumor, I would change the needle and go to the left-sided lymph nodes. And if it's positive for the same tumor, then I would go to the periphery of the lungs. If it's positive for a different tumor, then I think I can safely say right side belongs to the right side, left side belongs to the left side. In which case you may deal with 2, 3 A's.
So you got
Do-
a cytopathologist
Yeah.
on the road? Or
We have
tech.
cytopathology attending, we have cytopathology tech, and we have a cytopathology fellow.
We
Our
have,
room is crowded, and it's not COVID proven.
so we have tech, cytotech. Now, we can call it attending if we need to, but I'm not sure I would know with my rows that they were distinct.
What I think is really interesting about this, if the right-sided lymph node shows tumor, I don't know if I believe that belongs to the right lower lobe, subsolid nodule.
Not very hot.
I mean, how often do we see a 2R being involved with cancer from lung cancer per se? It's usually from upper lobe cancers, and you would expect a mass, not a ground glass, subsolid nodule. So if 2R ends up being cancer, I very likely intra-procedurally think of this as a 3B from the left, and then address the right separately. This is tough.
Yeah, and it's also curious just the variation in the SUV avidity among, because it also goes to your point, Rob, about the morphologies don't look the same in the primary lesions than the lung lesions. And so it really paints a picture where you have a lot to prove.
I guess the other thing I'll say is, when's the last time you were in tumor board and they said, why did you sample all these things?
We have the opposite problem.
I was going to say, we have the opposite problem. Why didn't you sample more?
Exactly.
Give me more.
I've never been chastised for sampling too many things.
All right, very good. So, oh, yes, please.
I mean, if you're going to do navigation, I think getting 2R would be complicated. Usually that wasn't T2, so I kind of like that Humphreys idea of starting with ELS and then having a backup plan. Results justify it. Can somebody comment on the length of bronchoscopy and your chance of getting a diagnosis in that right lower lobe?
Yeah, so the folks from MD Anderson have put together a couple studies now suggesting
CT,
that
yes.
as time goes on, you start getting atelectasis predominantly in the lower lobes more often, or in the dependent parts of the lung. And so that would drive that's part of my decision making for naving first, is I don't want to deal with atelectasis in that lower lobe. And I know I'm pretty sure I'm going to go after that lower lobe no matter what. So I would get it done first.
And how do you talk to your anesthesiologist about getting access to 2R when you do your late stage?
Yeah, I'd either pull the ET tube back at the end or swap it out for an LMA at the end if I can't reach it.
Give them
it's important to have a conversation with anesthesia before you even get started and let them know kind of what the process will be, and on-site will drive it. And I find if you have that pre-conversation, it goes quite smoothly. But it does require that conversation, I think, helps.
Again, this is a different approach. What's beautiful about this, I don't think there is a clear way of doing it. We can just rationalize our approaches. Atelectasis, I think we're talking a lot about it, but the reality is I don't think it's that common as in the studies that you read, like iLocate or VESPA, because it's just the settings are different. I think we all learned that we can keep the lung inflated and navigate really fast, don't suction like a maniac, and add the PEEP, decrease the tidal volume, increase the rate, etc. And then in a lesion like that, it's kind of hard to confuse that with atelectasis. When you see atelectasis, it's usually 3-4 centimeter in size, and when you put your radial EBUS in that lesion, you expect a 2 centimeter nodule, not a 4 centimeter mass. So there are ways with the EBUS to actually distinguish between the two. I'm not saying it's not common. We are aware of the literature. It's probably not as common as reported in those studies because we learned to keep the lung a little more open. The concern I would have with going to the nodule first, the right side, it's pretty close to the pleura. If I drop the lung and something happens, then I miss the opportunity to do so many other things in this case. There are so many lymph nodes. There is a left-sided lesion. So then what, Repeat the intervention. So I don't think there is a right way. I think we can hear both concerns. It's just I'm offering an alternative.
Where your pathologists commonly give you a difference on malignancies and distinguish adeno from squamous, our pathologists will not do that. They will just tell us malignant.
It really depends on the volume of tissue and the quality of the tissue you have. I mean, they can't really grab a diagnosis from the air, and sometimes they may be more conservative in terms of that. They may say malignancy, and if they can call it, they will call that, but it's not a guarantee. I don't think we can always be certain of that.
For us, most people would just refrain to make a difference between adeno and squame. They will just say non-small cell. But every now and then, if they see glandular formation, they would venture into saying, this looks like an adeno. They even say well-differentiated adeno on the slides. It's so pathology dependent to the point that on Monday morning, I pray for certain pathologists. But
Yeah.
Marcus.
Can I speak from a bronchoscopic third world country like Europe?
That's a continent.
Not many robots and so on and so forth. And I don't know, does the practice in the States now differ between your center of excellence and other centers that may not have robotic bronchoscopy here and so on and so forth. So in our center, what that patient would have, similar to what Tim said, was we one needle for 4 hour under conscious state, 1 needle for 4 hour, 2 hour, 1 needle for the 4 L. Depending on what we find, we just do fluoroscopic guided biopsy.
Sure.
Radiolocally.
Sure.
And presume the lymph nodes
Belong to someone. Sure.
Now, I don't know how that fair. I don't know, is there a difference between what's available in the States as opposed to the regional centers in the US? Does anyone have a robot or not? I don't know.
I think there's probably quite a bit of variation. Not all centers can do the robotic or the more advanced navigational procedures. So there is certainly a lot of variation here.
I'll just have one more question, and we'll move on for the interest of time, but please.
I'll try to find an old CT scan, especially if it's done recent times, to see if the right lower lobe lesion is altogether new and inflammatory in nature. That would help us a lot, especially if it was done there, let's say 2 months ago, and it's all
Sure.
there. It may more be inflammatory in nature, and we may have the culprit mainly in the left lung.
Sure.
Yeah.
You're saying you're being a doctor, not just a proceduralist?
Yeah. 35%, so again, living in histoland, 35% of my cases have bilateral nodules biopsied in the same procedure. Yep.
Okay, so I'm just going to move on. So this is what really happened, how I got it. So it ended up that the primary care physician ordered an IR biopsy of the right lower lobe lesion because that's what was recommended in the radiology report, and that cytology showed squamous cell cancer. The patient was then referred to oncology because now they have a cancer. They got a PET CT MRI, and that's what showed the significant uptake on the left and the right, and the discrepancy that we saw on the last slide. Then oncology said, well, let's order IR biopsy of the left upper lobe lesion, all without calling me, and I feel so sad that they didn't get us involved. But this is also kind of around COVID, so maybe they thought we were busy, and we were, but not for this. That would have been a great case. So anyhow, so that cytology on the left upper lobe showed an adeno. And then that's when we finally got them for EBUS staging. I'll tell you, my IR docs are really good. I really do appreciate the work.
Maybe not really good at looking at mediastinums.
No.
Which ours have a blind spot for on occasion as well.
They're just doing what we ask them to do, putting needle into things. Yeah.
And the other thing I'd make a point of, it's kind of an observation, is that the scan that we saw was a non-contrast CT.
Yes.
And just for all the fellows and folks out there, I mean, ideally, if you're really going to call the mediastinum in a methodical way, a priori before a procedure, it's ideal to have a CT with contrast, just so you can kind of be prepared. Even though you're going to do a survey with EBUS, regardless, that's the information you'd like to look at, just to be more certain.
Before you surprise us with the mediastinum, I surely hope that that's sarcoid and you're dealing with two primaries and you went for curative intent treatment for both lesions. But that will bring up the question of doing the CT-guided biopsy. In the PG course that we ran on Saturday, we reviewed this meta-analysis with the potential risk of seeding, which is not that rare. Thorax 2021 is the most credible one, but it's not the only one. And so now when patients ask me if there is a risk of seeding the pleura, I'm going to pause and say there is actually some evidence for that. So in addition to the 23% risk of complication from CT-guided biopsy and the fact that you get no staging, now we need to worry about recurrent tumor at the site of the CT-guided biopsy. Check that out. It's a fascinating read, Thorax 2021. So what's the mediastinum?
All right. So mediastinum showed the left 11L was negative for malignancy, 4L was positive for adeno. So we got a new needle, and just for the reason, because the left side was much more PET avid, so I was presuming it was going to be something different on the right. And 11R, 7, and 2R were all positive for squamous.
So two unnecessary CTN.
I'm sorry.
So two unnecessary CTN.
Yeah.
That's right.
Yeah.
No, that's
And so final staging was 3 on both sides, got chemoradiation, immunotherapy, and the patient's still doing well.
2 or 3 A's.
Yeah.
that's a good, interesting.
All right.
Yeah.
So all you needed was 2 needles
Yeah.
and an EBUS.
And a really good cytopathologist who make a call in the room.
Yeah.
Yeah.
And that's a challenge. I don't necessarily get that, but yeah, yeah.
You started the left hilum, or you started, what was your first biopsy site?
11L. We're just, yeah, just, I know, I was just going the left side. Yeah, it was really no, because I was like, I think it's, malignancy either way, so.
You ran 3 either way,
Yeah.
potentially,
Yeah.
Or in one.
or in one.
Right.
I mean, you're going to have to start and change the needle. This would be extremely useful to actually have a pathology on site to tell you.
Yeah.
Right.
Yep.
All right. So in interest of time, I'm just going to move on, but thank you, everybody. That was great, and that was a good conversation. All right, so this is the airway case, and Dr. Lam, I'll have you kind of lead this one. So we have a 66-year-old male patient, presents for diagnostic bronchoscopy for a right upper lobe endobronchial lesion and lymphadenopathy noted in May 2021. On-site cytology reported concern for malignancy. Post-procedure patients noted to be hypoxic with escalating oxygen requirements in recovery, admitted to the ICU requiring maximal high flow nasal cannula. Relevant history is this patient presented with hemoptysis back in April 2020 and had concerning findings on CT, but unfortunately he was working in the community, so I work at the VA, so our vets can get care at both places, and he was just further away from our center, so he was trying to get care in the community. It was during COVID, so having difficulty accessing any specialists, finally gave up after a few months and decided to come to the VA. And this was his pre-procedure x-ray, and it's a scalp film. We don't have an actual good one, so I just want to show that. And this was April 2020. This is just a few slices of his CT scan with relevant findings there. So that's what presented there, and unfortunately, a year later is when he showed up to get any kind of work done. So this was post-procedure. What happened, my partner was in there trying to get biopsies, and EBUS and all that, this is what he ended up with. So post-procedure I showed you, this is pre-procedure I showed you the scalp film, this is the post-procedure x-ray when he got to the ICU. And post-EBUS, so this is the ICU team decided to get an x-ray and a CT at the same time. And so this is what comparing from April 2020 to now, post-procedure. A year later, okay. And so, yeah, I guess I'll step back and say, what would you do next?
Right, so it sounds like he had a prior bronchoscopy, and it said there was concern for malignancy. Tell me more about that.
Yeah, so we had our cytotech, and she said, this looks like malignant cells. And so this was all in one setting, this has all happened. So the patient came in for a bronchoscopy, and then got tissue biopsies, and post-procedure was just struggling with dyspnea and had escalating oxygen requirements, and this is all in the same setting here.
And in the setting of the procedure, was there a debulk, any form of attempt to debulk?
No, this is diagnostic purely to get a diagnosis.
Okay,
Yep.
but you gave us an endoluminal view that showed complete obstruction, it appears, of really essentially the proximal right main stem.
Post-procedure, yeah.
Coming from, and then the tumor was initially coming from the right upper lobe and emanating from that.
Yeah.
So now you've got really complete obstruction, and maybe you've caused bleeding, and there's mucus and all the things that go along with the biopsy,
Yep.
Which has led to complete whiteout of the right side, and really single lung ventilation is what's
Exactly.
happening.
Yeah.
So you're asking me, what would I do next?
Yes.
Well, I think, we have the information that, there needs to be relief of obstruction, so I would do probably repeat the rigid bronchoscopy and go in and with a ventilating rigid bronchoscope, be able to control the airway, ventilate the patient, and also then do a manual debulking, but also maybe have a thermal therapy available in case for hemostasis, whether it be argon plasma coagulation or a YAP laser or something of that nature.
Exactly. All right, good. And I'm going to hopefully this video clip works perfectly. All right, so this was our first view in. Just a quick peek down there, and then this little guy. More of a big guy, but. And so that was just the first view. And so just like you said, debulking and trying to really open something up and kind of get a lay of the land in there, because that's kind of terrifying, and we see clinically it's obviously impacting him.
Would anyone do radiation first? Would you do radiation?
No, I think this needs an immediate intervention because the patient's unstable. They're hypoxemic, directly related to the obstruction. So I think relief of obstruction is important.
So it's interesting that even in people who are not sick, if they critically ill, if they have low bar atelectasis, there is actually data from like 80s that if you radiate, it's only 20% of people that open up the lung. So the outcome is much better if you successfully open the airway. Doesn't matter how you do that, and then follow with radiation. From the times when laser started in laser bronchoscopy, there are actually studies that looked at that, and successful radiation after you open up the airway versus just radiating, and again, with the 1 out of 5 chance of actually opening up the lobe.
Did you have the imaging, the CT? So this was almost a year between that first CT and then the post-procedure. Was there a CT done before the first
yeah.
bronchoscopy?
Yeah, there was one in April 2021.
Okay, but none, and then
Nothing
the,
more
and
immediate
then,
before.
Nothing
Yeah.
right before that, yeah. So this, it was done in May, but yeah, so
yeah.
nothing right before that, yeah.
So, sorry, May, a year, so almost 11 months apart then. Okay. I mean, the other thing I think about here is how long this lung has been down. I mean, if you got really hypoxemic in a procedure, then it suggests there's shunt and there must still be some flow. But contrasted scans, I'm getting more for these complete obstruction cases where I don't know the duration of how long the lung's been down. I don't know what I should be doing necessarily with that scan. But when I see no flow going to parts of the lung that I could potentially open, I wonder more about whether I'm going to do any good. In this case, clearly hypoxemic from a shunt.
Sure.
You could do some good.
Yeah. And so, I mean, Dr. Lamb kind of talked about all these things, but, and so this was my initial debulking attempt. So just really trying to get it with a rigid forceps just to try to open and kind of see where I am, trying to get a lay of the landmarks, see if I got demarcation of where things are, and reasonable to, of course, do it with a rigid because he's just bleeding and, just trying to control all that. So that was my initial debulking attempt. So I just have a few slides kind of going in and out of that. So at that point, just like you said, thermal therapy at APC. So again, they're kind of see if I could get that to contract a little bit. But then you can start seeing And so to the right, as your right upper lobe, that's where the lesion's coming from, and kind of medially there, you're starting to see this a little bit more, and hard to see, but I can explain to you that it was a little bit more friable, easier tissue to get at. The stuff coming out from the right upper lobe, the main endobronchial component, was really kind of rubbery and really difficult to even chip away off those rigid forceps and all that kind of stuff. So I was hoping to just try to see and find my way around there. And after working for probably a good 45 minutes, slowly, methodically, I was able to get a flexible bronch back distal, or beyond that, and this was the view from the BI, with the tumor kind of sitting at 3 o'clock. And so you could see the right middle lobe at about 12 o'clock, and lower to that, the right lower lobe, really pretty patent. There was a lot of secretions and things like that in there, not many blood clots or anything, but that's what we saw down there. And then towards the end of the case, we did clean up a little bit after this, but you can start seeing bubbling behind there. So we've opened up to some degree an airway, and we were able to get decent volumes in there. So I cleaned up a little bit more, dilated a little bit more, and got out of Dodge, and this is where we ended up, post. Anything different you would have done there? Would there indication for maybe a stent or anything like that? What would be your thought process of maybe doing that or considering that?
Well, I think it's important, you always want to try to see if you can cannulate and see, are you able to debulk to something viable? And you've established that with the bronchus intermedius, but there's still a lot of proximal tumor there. And, how do we know, I haven't heard what the pathology is. What's the response rate going to be with systemic and even radiation therapy in the interim? And you don't want him to run into the risk of having a recurrence of this emergent hypoxemia and that sort of thing. So I might even do some additional debulking.
Sure.
And really try to be flush with the right upper lobe takeoff. Now, how much can you debulk within the right upper lobe lumen depends. Sometimes you start debulking, it's just tumor on to the extent of that. So, and maybe you have a kind of a right upper lobe persistent collapse that you can't really fully recannulate until you get other treatments on board. As far as stenting goes, I'm kind of the mind that if you can debulk where you have a really patent airway and you don't have malacia and you have viable airway, even if you don't recover the right upper lobe in this case, because he was doing okay without the right upper lobe, theoretically he wasn't having significant physiologic effect before that, avoiding the stent is always an ideal. I would only consider a stent, and especially on the right side, it would be a partially covered stent. It depends on where the location of the pathology is. I wouldn't want to potentially jail off permanently the right upper lobe, so you want to have an output, a throughput for secretions and aeration in if you needed to. But in this case, I'd probably just do a local, pretty assertive debulking to maintain that main stem and the bronchus intermedius, get the patient to systemic therapy, and then have close interval follow-up and forgo the stenting.
Yeah.
Probably.
And that was my thought behind that, exactly. Glad you taught me well.
Can we offer an alternative? So, I'm aligned, absolutely. If we can avoid foreign objects, but one of the first things I say when I talk about stents, they're designed by engineers, not by God. They are foreign objects in the airway. So not everyone tolerates stents. They're prone to complications, like blah, 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 blah. But here, if I know the histology, that will help a lot.
Yes.
Because if this is small cell,
Big difference.
this is perfect what you've done.
Yes.
Start your treatment, it's going to melt in a few weeks, initially. If it's lymphoma, deja vu all over again. If it's a non-small cell, which smells like it because of the progression that you showed on your scans, then I would, this day and age, I would probably stent that. I used to be exactly what you're doing, Carla, like if you can avoid the foreign object. But that paper by Hervé Dutot from France made me change my practice a little bit, where he randomized people to stenting immediately after the debulking to just debulking alone in patients with exophytic endoluminal disease. We're not talking extrinsic compression or mixed. Exophytic endoluminal, and people in the stenting arm, they had less number of procedures than the control arm. So the fact that they actually got a stent day one, they actually did better from that standpoint. So I don't know. It's the time of COVID. He lost follow-up already. You don't know if they're going to come back again and when they're going to come back. If this was truly during the pandemic, 2020 or 21, I would have probably stented him. Today, I think I would have done exactly that. Maybe just clean up a little more,
Sure.
and then bring them for a close follow-up.
But I think, again, if you're concerned about a patient being lost to follow-up, then I'd be more concerned about a stent in the airway without proper, good management of the stent, because that becomes obstructing. It can be mucophilic, and it can be a problem too. So there's both sides of
I said
that.
the same thing.
Yeah, okay.
Absolutely.
Why no thermal therapy?
Which one?
But
I said, why no thermal therapy?
Thermal.
you mean like PDT, photodynamic?
Thermal, so.
Oh, yeah, I think I would always, because there needed to be hemostasis. I mean, there was definitely oozing. And so I think, I would use a laser or argon plasma. Those, I would probably choose one of the two of those. And it's important for folks to always make sure when you're working in that space, I like that you kind of highlighted that you were recognizing the normal boundaries of the anatomy as you were doing your debulking before you advance forward, because you can lose sight of the airway walls, and because the integrity is already breached, and you could get yourself into the mediastinum very easily if you're not cautious. The same thing holds true with intervening with the thermal therapy. You want to be parallel to the natural airway anatomy so that you don't run the risk of perforation beyond what what the patient already has.
I think that upper lobe is gone for a while. So if there was a decision to stent, this would be a right main bronchus to BI stent. Silicone, if you can pass the rigid safely. If not, just a SEMS and start your treatment. We do routine follow-up after any airway intervention, especially if we left a stent. For one thing, that was anchoring bias, because that's how I was taught. But now there is increasing evidence that stents after about 45 days, if you look at Lonnie Armas's paper from Johns Hopkins, especially for SEMS, after about 45 days, you have a significant number of complications. 65% of people had a problem that required reintervention, either granulation or migration or plugging, whatever. So they had to do something about it. So I find the evidence to justify my practice, but if you do leave a foreign object in the airway, especially if you start treatment and all, it will make sense to do actually surveillance.
It's also important to have the follow-up. So after they finish their systemic therapy, if they've gotten an excellent response, the stent should come out if it's no longer necessary, and that frees the patient up also all the better for that reason.
All right. So I'll move on to post-debulking. We had a PET scan during that same admission after that, and you could see the difference just kind of cleaning up in there, being able to...
Upper lobe open up? No.
No, upper lobe is still down, yeah. It's kind of medial, you can see it down there, but middle lobe and lower lobe opened up really nicely.
Yeah.
And I didn't leave a stent in, we just debulked and we were able to get away with that. And then post-treatment, you could see more upper lobe kind of, there's some stuff there, but it did open up quite a bit more. Some of it, that kind of medial aspect, anterior aspect is gone, I think, and that's been down since April 2020. But you could even see kind of the endoluminal area kind of retracted much more, and
What was the histopath?
treatment, yep.
The suspense is killing me.
Yeah, it was squamous.
Oh, squamous cell.
It was squamous, yeah. We got that back before post-treatment, but yeah, so he opened up nicely, and I spied on the chart, followed up, and he's doing really well. I was surprised at how well he did with all that, especially that first rigid. I was like, oh gosh, this is trouble. He's a relatively young guy, and kind of unfortunate that his care got delayed because of all the pandemic stuff and all that.
Did you do concurrent chemorats here?
I'm sorry?
Concurrent chemorats?
Yes.
I mean, the other point that is worth noting here is that older data now, but patients who present with airway disease versus those without that are the same stage, assuming they get adequate airway intervention, their survivals are the same.
There is actually reproducible evidence now that if you are opening up the airway successfully, we do actually improve not only quality of life, performance status, so they can get their systemic treatment, but survival. And if they are in the ICU critically ill, you take them off the ventilator and you change the level of care. So with that in mind, I remember with Dr. Rickman a few years ago, we're talking that our biggest enemy in interventional pulmonology is morphine drip. We should not have people talk about end-of-life care to patients who have airway obstruction until they get evaluated by somebody who manages airway obstruction. My analogy is always, if your patient suffering from terminal cancer shows up in your ICU with a massive PE, do you give TPA? Yes. They have pericardial effusion with tamponade. Do you call interventional cardiology to drain? The answer is yes. If they come with respiratory failure from a plug in the airway, let someone who actually manages that see if they can actually improve their quality of life. Now, we should not kill people with palliative interventions, but they should at least be evaluated.
Shot, yeah, absolutely.
Somebody comment on you mentioned some of the trajectory of getting into the ICU and the performance status leading up to that intervention. And so it's important that if it's respiratory that led to their ECOG status 4,
Right.
or colonoscopy or whatever, then yes, go for it. But if they were slowly dwindling and, their ECOG was 3 or 4, and we go in and we do an intervention, it is of no benefit in
That-
those patients.
Absolutely.
That's true. Good point. Any questions from the audience about this particular case or scenario? Yes.
You wish your colleague hadn't done the ELAS and just kind of kept it instead?
That would have been ideal, yeah, yeah. Yeah, exactly.
Your colleague
Yeah. I know she meant well, I think, but it would have been nice. I would have ran up wherever I was, whether it was clinic or something, and just be like, all right, why don't we just switch it to the OR? Because we'll do these cases. I mean, I probably would have done this case with rigid anyways, even if I'm trying to get diagnostic, right? Just for the reasons that we kind of talk about and reviewed a little bit here. But
But was there bleeding after EBUS, or was just a lag between the pre-op CT and the post-op chest X-ray? Because, one thing that I'm learning in patients suffering from airway obstruction, you may want to get the X-ray immediately pre-op, because then you get the X-ray post-op and whoops, what did I do? But did you do that, or
Was that
the
early?
lung actually closed from 2 weeks ago and I did a CT until the pre-op time? So what was the time lag?
yeah, so he actually came in essentially on room air to the procedure.
Okay.
So
Yeah,
it's
so he
much
came
more
in.
abrupt.
I was trying to help
I know,
out.
I was trying to make, I know.
This comes up though a lot. I mean, our colleagues at community hospitals around us will often, after the fact, they get a scan like this, they do a bronch for diagnosis, and then get into trouble, and it's going to need our help anyway. We try to open, everyone around here has our cell phone numbers, and we, text quite frequently with our referring docs and say, let's just get them here. We'll do the diagnosis at the time. You're just going to get into trouble doing this, or potential for trouble, and not really much upshot. So, but having those open lines of communication is helpful.
Good. Very good. All right, I'll continue moving on just for the interest of time, and if we have more time, we can discuss these at the end. So Dr. Murgu, this is for you. So I already give you a clue. It's a TE fistula case, but a 68-year-old gentleman presents with 2-month history of dysphagia with solids and now even liquid, reporting a 35-pound weight loss in the last 3 months. He had a CT chest that revealed a large midesophageal mass in June. EGD admission revealed esophageal adenocarcinoma biopsy. PET CT revealed bilateral adrenal mets. And palliative chemo was initiated shortly after that. So just to show you kind of he came into the ED in April 2021 with back pain, and this was his x-ray. So they said, there's nothing on here, give him some pain meds, and said, follow up with your primary care. And then this was in June when he presented again, after his dysphagia symptoms that were presenting. So pretty significant difference. And I'll give you the CT cuts. And you have the CTAPE, sixth vital sign. And then I'll give you the coronal cuts of that as well. Okay. So, yeah, we'll go there. So interval history since then. So he was treated with a course of antibiotics, concern of post-obstructive pneumonia. He actually only had a slight cough, despite all that pulmonary, kind of that parenchymal involvement. GI recommended after doing the EGD that he be on a pureed diet. And he was started on Folfox and nivolumab pretty quickly after his diagnosis. And actually in July 2021, after starting a few weeks of treatment, he started improving his tolerance to solid foods. And so he was doing well up until late November when he started to have worsening dysphagia. EGD was then done again. This is early December, and he had worsening esophageal obstruction noted. The plan was for repeat EGD with a stent placement by the GI docs, and I hadn't been called up until this point. And he asked me if I could bronch him simultaneously to see if there was extrinsic airway compression when he puts a big stent in or anything like that. And I told him, well, that was kind of a little late because there's some already, but. And so This is just an interval kind of scan in October. This is what we see.
This is after
backwards.
after chemo and immunotherapy.
Yes, exactly.
No radiation. There was no radiation.
No, there was radiation. Sorry.
There was
Yeah, yeah,
radiation.
yeah. And so, as he kind of said, he was doing well. He started swallowing and, things were getting better a little bit from that perspective. Then the lung opened up. And then this was in December when he presented again with the worsening symptoms. And then coronals here. All right. And so when I went in there, and sorry for the not so great pictures, but this was from the disposable bronchoscope that we had. But this is the picture to the left, the carina in the middle there, and then to the left in the left main stem, kind of over there is where we saw the nice little TE fistula. And so as my GI colleague was trying, his goal was to stent and try to see if he could open anything up, just palliative reasons at this point. He put in methylene blue saline in there, and we saw it leaking through. And he tried to get the wire in there, couldn't get the wire in there for the life of him, couldn't kind of traverse the esophageal obstruction at this point.
So
And
it's really
so-
a bronchoesophageal fistula, right?
So
Yeah.
can you go back to the image, just
Yeah.
so I understand it? The image on the left is LC2 with upper lobe and lower lobe?
No, this
It's
is
the
the
carina,
carina.
and then there's the fistulas in
Main
the
stem, yeah.
proximal left main stem.
Main stem,
That's
yeah.
the main carina?
Yes.
Okay.
Yeah.
Because I heard left main bronchus. Okay.
Yeah.
So that's main carina,
Yep.
right is fine, maybe mild compression, and then fistula very proximal. And then how did the left main bronchus look like? Was it open?
Yes, it was.
It was open. And that the second picture is just a closer view
It's
of
just a
the whole.
close-up, yeah.
Okay.
Yep, that's
Thank
all
you.
it is, yep. All right, so in terms of management options, what are your next steps? What are you thinking of trying to do for this patient?
And this patient already had chemo radiation,
He did, yes.
and now the tumor is progressing with the hole.
Yep.
So the first question I ask myself when I get a referral like this, is the airway potentially compromised if they stent the esophagus? And that's it. If yes, then I take care of the airway first. If no, I let them stent the esophagus because esophageal stents fit much, much better. Just remember, esophagus is a virtual space. When you open it with a stent, it molds just around. So if you're really serious about fixing the fistula, leakage of fluid and secretions, you want that intimate contact between the pipes wall and the stent wall. And that's better with an esophageal stent than with an airway stent, where you have a mismatch between the shape of the airway and the shape of the stent. The concern is, and we've seen that several times, right? GI goes in, they deploy a stent, and I really don't understand why they place 18 and 20 and 22 millimeter stents when the esophagus is a virtual space, but whatever. So they put these large stents, and then where is that pressure gonna go? It's not gonna go towards the spine posteriorly. It's gonna push the airway anteriorly, the tumor anteriorly, and it's gonna close the windpipe. We had asthma attack after an EGD with esophageal stenting. Intubated, ICU, you go in and it's a virtual space. You need to take them emergently, put a wire and deploy a stent in the airway so they can actually breathe and ventilate. So the question that they had for you, I think, was very appropriate.
Yes.
Come and take a look at the airway. What do you think? If the more challenging cases are actually not this. This, I think, you do. If their airways are not compromised, I think you're okay with going with an esophageal stent and be there and just watch. And then wake the patient up and see if they're short of breath, whatever. The cases that are more challenging are when there is no tumor, like after chemoradiation for esophageal cancer. And now you're dealing with a big hole, and that there may be no cancer anymore. So you're potentially dealing with a benign fistula after curative intent treatment for esophageal cancer, and there is nothing to hold the stent in place. And then you put a foreign object for long term, and those are the fistulas that just continue to get bigger and bigger. So in here, there is progression of tumor. I know you probably expect me to talk about double stenting and all that. I highly discourage that practice. My mentor published on that in the past. I think it's delusional to think that you have two foreign objects rubbing against each other, that hole will actually heal. So here, I would say start with an esophageal. Be there, make yourself available, and see what happens.
Please.
Before you talk about symptoms, to me, the first question is what symptom are you trying to validate? And I didn't hear any
Yeah.
Recurrent aspiration pneumonia, yeah.
So, yeah, it's a valid.
Well,
It's a,
peg tube doesn't prevent aspiration, though, and there's still a communication.
yeah.
Yeah, even that doesn't prevent aspiration.
So people have looked at that already, right? A fistula like this, malignant TEF, or in this case, the right term is actually esophagorespiratory, because it can be anywhere. If without any treatment, just with the best supportive care, the median survival is 3 weeks. And they die from sepsis. So I don't really care for dyspnea. In this case, patient already had history of pneumonias. I think that hole is generous enough where aspiration will be important, even by bypassing completely the esophagus, right, or the G tube or a J tube, just swallowing saliva that's all contaminated. Where is that going to go? It's going to go in the airway.
Did you say that the gastroenterologist couldn't pass the guide wire?
Yeah, so,
Oh,
Yeah.
so then I
He
guess.
couldn't deploy a stent.
yeah, so
He
that
could
was
not
right.
deploy the
But yeah,
stent.
he was not able to deploy a stent.
Okay, I mean, in that case, then you're committed to an airway stent. And now you're going to ask me, what airway stent do you place so proximal to the carina?
How about a custom stent?
Ooh. So custom stents right now in this country are only available in Y-shaped. I guess you can do that and put a lot of plastic to cover a hole that's about 5-6 millimeters. I would say any Y stent here would probably be an overkill. I think I would start with a fully covered, starting exactly from carina and going down the left, and then see what happens. By the way, for fistulas, fully covered are probably better than silicone because the radial force is much higher with silicone, so the hole can actually get bigger. Partially covered is not going to cut it because the distance so the segment that's uncovered, it's 7 millimeters proximally and 7 distally. So this one is too close to the main carina, then it's going to leak around. So I think I would go with a fully covered, starting from the main carina, and I don't know, 3-4 centimeters, whatever.
Sure.
And then follow up. Do an esophagram and, see what happens.
Yeah. So what we opt, and this is something you've published before, but I think it was a good kind of flow chart of kind of what you've already discussed essentially and shared with us.
So I agree with myself?
Yeah, exactly.
Consistent.
Consistency is good, yeah. So what ended up happening was that, because the patient didn't really have any significant respiratory symptoms, and I agree he did have aspiration previously and things like that, we did see the like I said, leaking through the fistula. GI wasn't able to intervene, and so we actually just aborted the procedure at that point. Patient was made strict NPO. We talked to him. He actually elected to have less done. So he said, I don't want any more of this stuff. He said, whatever time I have, if I can just get time, we'll do that. So strict NPO, surgery placed a G tube just to get something in him, transferred into hospice care. And-
Absolutely nothing wrong with that.
Yeah.
That's definitely an option. The question is, can we help without hurting at the end of life?
Yeah,
So, you had two options really. So.
exactly. And so he
Any
chose-
other approaches from the room?
It's a terminal diagnosis. How to manage symptoms.
Any challenging cases from the audience that you want to run by?
I would say, while you're thinking about that question, I would say in patients with that tumor or the original diagnosis, I would encourage, and we talked to our GI about that, an early bronchoscopy. Because if the airway wall is involved, post-treatment, the hole is going to happen. It's not even a question. If there is tumor involvement and the tumor dies, what's going to happen in between? So I think we can be a little more proactive about it. Radiation is definitely an independent risk factor for this, and so is Avastin for people who get bevacizumab, because it's, inhibits proliferation, vascular proliferation, etc.
Could you come to the microphone just so the folks can
The
hear?
first case with the bilateral synchronous primaries, I mean, not a surgical candidate, based on that evaluation. Is there any data to suggest like that matters that much if you can prove, if you have, obvious malignancy bilaterally? I mean, I like to biopsy everything too, but just, trying to build the case for doing that.
So I think there's certainly data that staging patients appropriately improves their outcomes in general, even if this patient could not have surgery as part of, that's pretty common in our patients, and pretty common in our synchronous primaries. Patient might have enough for maybe a lobe, and then we talk about, do we wedge the other side? If we prove or we're comfortable with it being synchronous, do we SBRT the other side? We get into these kind of creative, this is more the art than the science sometimes. So I think I still would have staged this patient as well as I could have, even if they weren't going to be a surgical candidate for that reason. And then this is where a tumor board is helpful for cases like this. The synchronous primary case is rarely cut and dried, and I think having folks look at it who come from different perspectives to kind of look at different aspects of the case to help decide, is this really synchronous? Is this metastatic disease? Let's get all the data and all the people that we can, is really helpful for a case like that.
It clearly made a difference because they treated that as 2, 3As, not as stage 4.
Right.
Yeah, and not as a stage 1, stage 3.
One other point is that, we just talked about this in the last session, is that, so if you were to do molecular next-gen sequencing with that, you might have two different outcomes, and you'd want to carry your drugs, potentially sort those, and you also wouldn't want to give somebody with squamous cell carcinoma bevacizumab, which is in some protocols.
Yeah. The other thing about staging that I think is changing, and I wonder what you all's thoughts are on this. So with Checkmate 816, staging guidelines to date have largely relied on, mediastinal disease, because that changes immediate surgical management, right? If you have mediastinal disease, you shift to a different way. Now, if you have ipsilateral hilar disease, you're stage 2, and if you're a surgical candidate, you're in Checkmate 816 land with chemo-IO. And so I don't know if that's changed any of your practice so far. It's another reason in my mind to be aggressive about staging almost everybody.
Yeah, it is starting to change our practice because it's being offered up front like that. Neoadjuvant.
And PD-L1 is like standard of care even for early stage now, for neoadjuvant reasons, and increasingly moleculars. Right, what's the study, Adura or something? Well, I forgot the name of the study, but you're going to need EGFR as a neoadjuvant treatment. So when we go to, forget the lymph node, I'm talking like robotic scopes and all that, we're going to need enough material for PD-L1 and molecular testing,
Right.
which is kind of cool for us. It's a little challenging. We don't even know yet how good the peripheral bronchoscopy is for molecular testing.
Yeah, our oncologists are asking for molecular on just about everything, maybe exclusive of a peripheral 1A.
Right.
But you're probably, many of you were in Dr. Rigsman's session, and I don't know if this was covered because, I missed it, sorry. The molecular thing, talk to your lab because honestly, we have no problem running it, and I promise you, it's not because of what I do. Because I put a needle in the node just like you do, and I do the same biopsies in the periphery of the lung. It's the amount of DNA that my molecular lab is requiring, which is in the range of 5 nanograms. That's 3 slides prepared on site. And the rest, we drop everything in cell block for PD-L1 and TTF1 and P40, for which they need 200 cells or whatever. So it's really the molecular lab. If your molecular lab works with companies that requires 50 nanograms of DNA, that's really not your problem. You have an internal problem, talk to your oncologist to change the lab.
All right. With that, thank you everybody for attending, and thank you our faculty for such a great discussion and conversation about this. Really appreciate everybody being here, and please don't forget to evaluate the session in the app.
Safe travels.
Thanks, Christina.
See you in Hawaii.
Exactly.
you.